Welcome everyone to the TASHNp Innovation Fellowship Midterm Presentations, Day 4. So we have Lisa D. Prospero, Director of Practice-Based Research and Innovation at Sunnybrook, to give us some opening remarks. Thanks, Lisa.
Thanks, Sarah. I'm so thrilled to be able to be part of the faculty of the fellowship program, a partnership between Sunnybrook and UHN. This program offers the opportunity for our frontline clinicians to move an idea into action. At the onset, I want to acknowledge the senior leadership of both organizations, especially our executive sponsors, Ms. Ruth Tiger and Dr. Joy Richards, who send their best wishes to all our fellows today. Rue and Joy are so proud of this program and provide continued advocacy to sustain and grow it from year to year. Thanks also to all of our donors who provide generous gifts from both organizations of support in sponsorship of the program. And I would be remiss not to also thank Michael Guerin Hospital for joining our program as we continue to build our collaborative networks. We're so thrilled to have Sarah with us this year. This is my third year with the program. And each year, I'm more amazed at the courageous journey, not only of the projects you take on, but more importantly, within each of you as you listen, learn, absorb, and share the curiosity that feeds your inquiry. Over the last 3 months, I've seen each of you stretch yourselves into the uncomfortable with commitment and dedication. Thank you for allowing all of us, the faculty, Sarah, Deborah, Carrie, and Nicole, Guna, and Bridget, and myself, to experience this with you. Although in March the official program will end, your journey is just at the beginning as emerging leaders who will continue to impact care locally and beyond in your new roles, your new projects, your new ventures. Your passion has been ignited and there's no turning back now. And you could just talk to any of the other fellows that have graduated and we just see them emerging as impactful leaders at all organizations. As we start our day, I leave you with the words of Jeff Bezos: work hard, have fun, and make history. Thank you.
Thank you, Lisa. So, to get us started here today, we have Miriam from University Health Network.
Good morning. My name is Miriam Hendricks. I'm a nurse at Toronto General Hospital at the thoracic surgery and respirology floor. Before I will start to talk, I will show a little clip of a video.
You remember?
Hello, I'm morphine. I got the whole thing.
I'm so sorry. I didn't mean that.
Of course you didn't. You love me too much to shoot me with morphine even if I asked you to. And my stupid arthritis coming back.
I'm so scared. I don't love you anymore. Back. You're back. Is he?
So this clip says it all. The sudden death of a patient can be traumatic for staff. It may cause them to sleep poorly and relive the experience repeatedly, and it might even put them at risk of developing post-traumatic stress symptoms. Nurses and other staff are often the first to deal with the family members and visitors of the patient that passed away, and the emotions of the visitors will increase the stress that the nurses and other staff members will experience. Nurses and allied health will call social work, we will call spiritual care, but once the family members and visitors leave the hospital, we really don't know what happens to them. In the spring, I witnessed twice the sudden death of a patient on my floor, and I realized that a gap exists. Staff are often not aware of supports available in the hospital and outside of the UHN. For themselves and for visitors. And I want to say visitors because when a friend is visiting a patient that passes away, this person will be affected as well. So that leads to the aim of my project. The aim of my project is to develop 2 brochures, one for visitors and family members, and the other one for nurses and allied health. So the brochures should help staff and visitors to find appropriate support services and resources. Another aim is to make the nurses and allied health on 10 Eaton South aware of those services and supports. So I say 10 Eaton South, that's the floor where I work. Now I will explain how I will get there. Before applying for the fellowship, I spoke to many nurses from different floors at the PNPC meeting. And the lack of awareness of support services and resources was found to be a problem. My colleagues did not know where to look for those resources for themselves, but they also did not know what to tell visitors after they left the hospital. My colleagues encouraged me to develop resources that would inform them of those supports available, and this inspired me to write a proposal and to apply for the CAP fellowship. So far, I have focused on the needs assessment and the collection of data, and the empty boxes will be filled later in the presentation. So it might be clear that there's a need for resources that I plan to develop, but of course I needed to find out if it already exists. So I did a search on the intranet and I didn't find any of those resources. And I also spoke to the family and patient librarian, and she did not find any resources either for visitors. There are actually very many helpful resources for visitors, but they deal not with sudden death. So then I went on to explore staff needs. So I held 2 focus groups, one during a unit council meeting and one during a staff meeting, and in total 11 staff participated, including my nursing manager, social worker, and the nurse educator. In addition, I did a survey under the allied health and nurses on my floor, and in total I got, since yesterday, 16 people who responded. I will mention some of the highlights. Nurses felt they were lucky to work in a large organization such as the UHN because spiritual care and social work are readily available and they are regularly accessed as well. All employees have access to the employee assistance program, and that program offers supports for a variety of needs, including stress and trauma. So it would be really applicable to the trauma of sudden death as well. However, many staff do not know about the plan. As you can see in the graph, this graph shows nearly 50%. Yesterday I got an extra respondent and now it's 50-50. So 50% does not know about the plan. And my colleagues during the focus group told me that they want to raise more awareness about this plan. During the focus group, it was also discussed that the brochure should acknowledge and validate that witnessing sudden death is traumatic, and generic information about dealing with sudden death and with grief should be included, both for staff and for visitors. This month, not this month, I spoke yesterday to the patient partnership. Next month, in January, I will have a meeting with a patient partner. She experienced the sudden death of her husband in the UHN, and her experience with support will be used to write a brochure for visitors. And then after I found out what staff wants, I went to look for resources. To find resources, I spoke to many people. The service they are working for include human resources, occupational health. I sent an email, I had an email exchange with wellness at UHN. I searched the intranet and I searched the internet. And I found many resources, a wide range of resources that can be used in brochures. Then I went about finding resources for visitors as well. I contacted many services again, including the Family and Patient Librarian, Family and Patient Education Department, Spiritual Care Social Work, and again the Internet and the UHN intranet. So as I said before, the UHN has many resources for family members, but I found that they did not focus on the sudden death experience. Many resources that I found for staff can of course also be used for visitors and vice versa. For example, Toronto Family Services offers counseling for trauma. It has been a privilege to connect with so many services and people in the first 3 months of my fellowship. The interactions provided valuable learning opportunities. Other learning opportunities include, and there are many more, but they include developing focus groups, working on my leading, leading focus groups and writing surveys. And what I found really very handy was developing an elevator pitch, because I work on a very busy floor and my colleagues are curious what I'm doing, and being able to explain my project in 40 seconds was very, very helpful. So the next steps. So the first 3 months I focused on the assessment of needs and the collection of data. The next 3 months I will work on developing the brochures. I want to finish the brochures by March 8th and then educate my colleagues about the brochures by March 15th. To make sure that the brochures will be used after I finish in March, there are many strategies to follow. We will inform as many services as possible, for example, spiritual care, social work, and the patient and family librarian. We will place brochures for visitors in a slot at the patient education hall on 10 Eaton South. And every 3 years, we will make sure that the brochures are up to date, the content and also the resources. We will develop a website that will give the same information for staff, so that would be easy. The content of the brochures will, of course, be applicable for every nurse, for every allied health worker, for every floor that experiences sudden death. So I will also work towards raising awareness among my colleagues on other floors. In conclusion, nurses and allied healthcare staff are very much affected by the experience of sudden death of a patient, and this can impact on their emotional well-being. Emotional well-being will be improved by timely access to support services, and the brochures will help with this. Staff will also be empowered by being able to assist visitors find appropriate resources. Emotional well-being will not only benefit the healthcare workers and visitors, it will contribute to the health of the UHN as a whole. Thank you for your attention.
I want to say that great presentation. And
Thank
I
you.
love also the fact that you're still learning from seminars, the elevator pitches, to further your project. It's fabulous.
Thank you.
Your interactions with individuals were surprises in terms of the information provided.
I think I was most surprised by the knowledge and the services available and the information they can give. For example, I went to the Patient and Family Education Center, and I guess they're the experts in developing brochures, but she gave me so many ideas of people I could connect to talk about resources. And that ranged from talking to RJ, who's in the MATE program, to the patient and family librarian. And yeah, I was very impressed with that. Yeah, thank you. Any other questions? Sarah.
Great presentation.
Thank you.
Will you have a chance to evaluate the brochure with your patient card? In general?
Yeah. So the question, Sarah's question is, after I have written a brochure for family members, will I be able to evaluate the brochure with the family member that I'm going to see? So that is a possibility. What I am planning to do is to use her information and her experience and develop a survey for the virtual focus group in UHM. But for sure, if I think it would be beneficial, I will for sure include her if she wants to. Yeah, thank you. Thank you.
Thanks again, Miriam. Just give me a second here, guys. Can't seem to find this presentation. Okay. This isn't here, right? Huh. Lisa, do you have any suggestions? Do you know how to use the... Yeah, like, not all the presentations are in the program. So, not really sure how to do that. What we could do is skip to a different one that is here. Sorry? Yeah, we could do that. And not you?
No, you can have half my face and half the screen.
Right. Yeah, I guess we could. Should we do that? Okay. That's nice. It looks like it's, is anyone logged in online? Are you logged in online? Because it says stop share. So I wonder if, oh look, there it is now. Oh good. Okay, we're back. So up next we have Medette from Sunnybrook. Thank you, Medette.
Good morning, everyone. My name is Medette Galpin. I'm a radiation therapist at the Odette Cancer Center, and my quality improvement project is on implementing daily team huddles on the radiation therapy treatment floor. So the Odette Cancer Center encompasses a large academic radiation therapy department that houses 10 treatment units and can see anywhere from 25 to 40 patients a day, meaning there can be close to 400 patients that walk in and out of our doors on a daily basis. And in addition, we can have close to 45 therapists on the treatment floor at one time. Our workload includes providing treatment care and patient care to our patients, checking our patients' charts, and providing patient education on their first day of treatment. Sometimes our workload can be affected by different factors, such as machine breakdowns, patient issues, or different patient setups. Sometimes there can be an uneven distribution in the workload, meaning sometimes there are patients that will have treatment and our machines will be finishing their workload faster than other machines. So, for example, when there's a machine breakdown, our patients are booked back to back, and this can affect the amount of time that they wait for their treatment. This is especially important when we have patients who require that they have, for example, a full bladder for their treatments. Our machines can be categorized into what we call sister machines, meaning they are clinically identical and can treat patients from their sister machines. So if we're running behind, one thing that we do is transfer the care of our patients to our sister machines. This idea is to help reduce the amount of time that a patient waits for their treatment. So this is what a typical day on the radiation therapy treatment floor looks like. The pink boxes represent points in time when we communicate with each other within a unit, and this can happen on a daily basis. The yellow boxes indicate points in time where we can communicate with our team members from sister machines. And this kind of communication is done informally, on the go, usually when we're already behind, and can be variable in its content. From the literature, communication breakdown and teamwork failures have been indicated as key factors in the occurrence of patient safety incidents. Structured communication, such as SBAR and debriefings, are already in place on the radiation therapy treatment floor. However, briefings or huddles are not, even though they are best practice tools identified and aligns with Sunnybrook's quality strategic goals. So I really wanted to understand how a team huddle takes place on the treatment floor or in a hospital setting. So first I went to visit the brachytherapy unit at the Odette Cancer Center. Their morning huddles involves an interprofessional team of doctors, nurses, physicists, and radiation therapists. They discuss factors regarding the patient's treatment plan, any comorbidities that the patient may have that might affect their care, and any of the patient's concerns or goals. The second area that I visited was the C3 Dr. Brian Gilbert Cardiac Intensive Care Inpatient Unit. This morning huddle involved the staff as well as the patient care manager, and they discussed differences in patient bed flow, patient statuses, any meetings throughout the day, such as family meetings, and a reminder of best practices. One thing that I really liked about their huddles was at the end, they gave a round of applause to any staff members for achievements or celebrations. Third, I conducted a telephone interview with my colleagues at the Radiation Therapy Department at Princess Margaret. They have a team huddle that's done on a daily basis within each treatment team, and they discuss issues that might affect their workload as well as opportunities for improvement. Since patients are being transferred to different sister machines as a way to help reduce the amount of time they're waiting, I wanted to make sure that I was capturing their voice within my project. I created a patient survey and distributed to patients on units 3, 4, and 9. There's no surprise here that most of our patients had to wait more than 15 minutes for their treatment. When I gave them the option of whether they would prefer to wait for the regular treatment team or have their care transferred over to another treatment machine, most of my patients said that they would rather choose the latter because that meant they didn't have to wait as long. Now, out of the 13 patients who filled the survey, 11 of them had stated that they experienced a transfer of their care between sister machines. All 11 of those patients said that they were satisfied with the care that they received from the team members of the sister machine. In addition, 2/3 of them felt that they were comfortable enough to discuss their issues or concerns with team members of the other machine. So having a daily team huddle on the radiation treatment floor would be a good way of regularly having a conversation with your team members from your sister units and coming together and discussing any issues with workload and ensuring that your patients have a continuity of care. In addition, team huddles would provide a good opportunity to formally recognize and celebrate any achievements or accomplishments of your team members. This can lead to a boost in team morale, which is really important because low team morale can lead to high stress levels, an increase in professional negligence, and poor professional behavior. Altogether, team huddles can lead to a more positive patient experience during their cancer journey. As you can see, the radiation therapy department is a very complex environment and requires the teamwork of a lot of team members. My aim will be to pilot team huddles on units 3, 4, and 9 to improve the amount of intra-professional communication among the radiation therapists by 20% and to boost team morale by 15%. So here are a few of the different measures that I'll be keeping in mind during this whole project. In order to establish a baseline for the amount of communication and morale on the treatment floor, I created a survey that had some components from the team steps questionnaires. I distributed these surveys to the staff who worked on the treatment floor and had an 85% response rate. While most of the therapists had a positive attitude towards the importance of communication, only 24% felt that there were sufficient opportunities to really discuss patient workload between the sister machines. And in regards to team morale, the survey demonstrated that only half of our therapists actually feel that there is high team morale on our treatment floor. Staff were also given the opportunity to express what topics that were most important to them to discuss with their sister machine. Together with the feedback from the survey, the literature review, and the environmental scans, I created this huddles checklist. This checklist was then distributed to the treatment floor staff for their review, and we came together during our weekly staff rounds called Quality Conversations. Feedback was given during the Quality Conversations, and I took it and did a second draft of my checklist. So this is my TSA cycle for the process. Once we had the new draft, again, the next week we discussed again in Quality Conversations, and now I have my final draft of the checklist. This final draft has 4 main domains: workload issues, staffing issues, patient needs, and team celebrations. Going forward, I'm going to be creating a team huddles evaluation form that will help me understand how well the huddles are going and to gather feedback from those who are participating. This will be important for my future PDSA cycles. I'll also be creating a lesson plan for the education sessions in December. These education sessions will allow the participating therapists to really familiarize themselves with the checklist and to give them the opportunity to practice the huddle. I'm aiming to start the pilot on units 3, 4, and 9 in January next year. And hopefully by the end of February, we'll have the implementation in place, and I'll start thinking about further spread on the treatment floor and sustainability. So from the beginning, I had a few early naysayers, but what I took from that was that all feedback is good feedback. Some of the concerns included that there wasn't going to be a protected time to really perform the huddle throughout the day. So some were concerned that it would be difficult to orchestrate the therapists to come together, and it might be taking time away from other clinical duties. So the checklist was created so that it would provide structure and help to streamline the conversations of the team huddle. And hopefully the huddle will not take more than 10 minutes out of their time. Another concern that a therapist mentioned was that if 2 of the machines are actually physically located beside each other, there's no real need for a team huddle. So I addressed this concern by incorporating 3 treatment units, 2 of which are actually located beside each other and one that's located a little bit further down the hall. And this will help me see if proximity really has a factor in the huddle process. The second lesson that I learned was that not only was it really important to have the support from management, but also to have the support of your colleagues. So the top-down support from leadership, as well as the bottom-up support from my colleagues and the early adopters, is really what's going to help my implementation and sustainability of the team huddle. So in conclusion, effective communication is a very important quality for high-functioning teams. In addition, it's very important to also acknowledge and recognize and celebrate these accomplishments between your team members. The huddle is a tool that can really achieve both aspects, and if used properly, can lead to a positive patient experience. Remember, a team that huddles together succeeds together. A quick thank you to the TASHNp and PBRI and the Radiation Therapy Innovation Fellowship for giving me the opportunity to investigate this quality project. Thank you to my mentors, Ruby, Glenn, and Laura, for their continuing support, as well as Steve, my manager, for his ongoing support. Thank you to all those who helped me with collecting data, and my colleagues who helped with their participation and feedback, as well as all the patients who helped with the survey. Because of you, this is the reason why we're doing quality improvement projects. Thank you. Any questions? Yes, sir. So the question was, are there any ideas for future spread, including interprofessional inclusion? So right now I'm concentrating on the interprofessional communication, but we do have other team members from different professions, such as nursing, that can hopefully be a part of the team huddles in the future. It'd be great to have a space where there can be an interprofessional quality improvement projects where we can display what's going on in the center. So maybe that's a possible idea. But the team huddle idea is not new to the hospital setting. It can be used in any outpatient or inpatient unit. I'm really trying to showcase that the huddle can be used in an intra-professional setting, as well as it's been successful in the interprofessional setting.
I think we're good. Up next, we have Katie from Sunnybrook.
Hi everyone, my name is Katie DeCaria. I'm a pharmacist here at Sunnybrook, and I provide clinical pharmacy services to D5, which is our neurosurgery orthopedics ward. My project is looking at pharmacists prescribing for minor ailments in hospitalized surgical patients. So firstly, I'd like to talk about why I chose to use this as a project. So I worked on many different surgical floors within the hospital, and it's a common problem when patients have self-limiting conditions such as rashes, dyspepsia, topical fungal infections. It can be difficult to get an order for treatment from the surgical resident. So one particular case was a D5 neurosurgery patient who was a young girl, and wasn't able to verbally communicate how uncomfortable she was from her minor rash she had on her chest. So she was visibly scratching at it and had scratch marks on her chest from it. And her father was quite concerned about this. Her nurse had asked me to come in, have a look, see if I had any recommendations or thought maybe we should have dermatology. With just a minor rash, so I recommended a hydrocortisone cream, and we paged the surgical resident on call. However, the surgical resident didn't get back to us at all. So the patient's father actually went out to a community pharmacy, went to an aisle like this one, and bought some Benadryl cream, thinking that'll help my daughter. It didn't. And Benadryl cream is known to be very ineffective, and it can actually worsen rashes. So she was still scratching, still visibly uncomfortable. And her father was quite upset because he felt that we weren't doing anything about something that was important to him and his daughter. So currently, our ideal process map is that when a patient complains of symptoms of a minor ailment, such as a rash in this case, they usually inform their nurse, who's the healthcare professional they see the most often. They sometimes will be able to tell the doctor or nurse practitioner on the floor. In most cases, staff come to the pharmacist on the floor to ask for recommendations for treatment. Ideally, a prescriber is available on the unit and is able to write an order for treatment. The order gets sent to the pharmacy and the patient receives the treatment. Most of the time, residents aren't available on the floor, so we page the resident on call, and ideally, the resident gets back to us in a reasonable amount of time so we can get an order for treatment for the patient. Unfortunately, that's usually not the case, and the resident doesn't get back to us. This leads to sometimes the patient's family member bringing in over-the-counter medication to self-medicate, which can lead to risk for adverse events, drug interactions, and often ineffective treatment. The symptoms get left untreated, which is increased discomfort for the patient and increased frustration for the staff because we feel like our hands are tied because we can't help our patient feel less uncomfortable or treat these minor ailments with things that are typically available over the counter. So there's frustration with the amount of wait time for treatment with drugs that are typically available over the counter for self-limiting conditions. And there's increasing constraints on the prescriber's time, the surgeon and the nurse practitioner. And these issues are typically deemed as non-urgent and are low priority compared to other issues that present themselves. Pharmacists are typically available on the ward during the day. All the surgical wards have a liaison pharmacist. And we're trained in managing minor ailments. And in the community, we protect patients from potentially inappropriate use of over-the-counter drugs. In one study, it was shown that 98% of interventions for patients suggested by a pharmacist were accepted by surgeons over a 6-month period. So my overall aim statement is to increase patient satisfaction with the process of receiving treatment for minor ailments at Sunnybrook with the D5 neurosurgery patients by March. I hope to do this by getting a medical directive to be able to order treatment for certain minor ailments in those patients. At this point, I wanted to look at a needs assessment to see how staff and the prescribers on the neurosurgery team felt about if a pharmacist could prescribe, if they were confident that a pharmacist could order treatment, and if it would be beneficial. So my outcome measures overall would be patient satisfaction, but I also wanted to look at the staff perceptions of pharmacists ordering for self-limiting conditions. I'd also wanted to look at prescriber confidence in pharmacist prescribing, if they thought that, yes, the ward pharmacist can order treatment for my patient. I'd like to look at the time it takes between first paging a resident for an order for a patient with certain self-limiting condition to actually receiving treatment. And as balancing measures, I want to look at the number of orders for selected medications used to treat minor ailments before and after the medical directive is implemented, and also to see if there's any impact, major impact on the pharmacist's time or workflow during the day. So I surveyed staff and the prescribers on the neurosurgery team. And as for staff, 83% agreed that it would be very helpful for if the pharmacist on the floor could order treatment for these minor ailments. They're actually very excited that this could potentially happen. And the staff that were surveyed were mostly D5 nurses, but also AC and RT nurses, which are our float nurses that go to different units, as well as some allied health. 88% of the staff surveyed agreed that the current process of obtaining orders for these types of minor ailments is very frustrating. So of the prescribers that were surveyed, which included the majority of the staff neurosurgeons, residents, the fellow, and the nurse practitioner, all agreed that they were confident that the ward pharmacist can order medications for their patients when it comes to minor ailments. And 56% identified frustration with the number of pages that they get for seeing patients without minor ailments. So I think that was mostly the residents that we paged. So if I am able to get a medical directive, my proposed process map would include another pathway for the patient to receive treatment. So the nurse or staff member or doctor would be able to consult the pharmacist to assess the patient to order treatment if appropriate. And the pharmacist can write the order, and then order gets sent to pharmacy and the patient receives treatment. The doctors and the nurse practitioner can still order treatment for the patient, but this leaves another pathway so the patient can hopefully more efficiently get treatment if they are unavailable. So as for next steps, I need to do some more patient surveys to get feedback on the current state. I am having some difficulty with the neurosurgery patient population just due to some inherent issues that they face due to brain injuries or recent brain surgery where they may not be able to verbalize how they feel. So I'm thinking of broadening my surveys of patients I survey, to other surgical services at Sunnybrook, particularly the orthopedic patients, which are also on D5. In future, this may help in broadening this directive to other surgical services at Sunnybrook and other pharmacists. I'm currently in the process of applying for a medical directive to order selected medications for neurosurgery patients admitted to D5. There are some exclusions. So, for example, nausea and vomiting is excluded from the list of minor ailments that I would be able to order treatment for because nausea and vomiting can be indicative of something more serious in a neurosurgery patient. The limited list of medications that I would be able to order has been approved by the P&T committee last Tuesday. So my next step is to go to the medical advisory committee to seek approval for this directive, which would hopefully start in January 2019. So in conclusion, staff and prescribers agree that it would be beneficial and that they're confident that the pharmacist on the floor can order treatment for admitted surgical patients. And the majority of staff find the current process difficult to get orders for their patients for these types of things. If the pharmacist on the unit was allowed to, given the ability to order medications for these types of self-limiting conditions, it would be utilizing a resource that's already readily available on the ward and within their scope of practice. So in the case that I first talked about, that patient would have been able to get treatment, effective treatment, more quickly, and her father wouldn't have had to go out of his way, go to a Shoppers Drug Mart and spend his own money on a Benadryl cream that didn't do anything for her. So lastly, I'd like to acknowledge the Sunnybrook Department of Pharmacy, Sunnybrook Practice-Based Research and Innovation, Claudia Bucci, my mentor, Danette Beechnor, my Director of Pharmacy, Bill Cornish and Romina Marchesano, who were extremely helpful with the process of applying for a medical directive, Jerry, my manager, Julie McDonald, our neurosurgery NP, of course, the staff of D5, who've been extremely helpful with this project and very enthusiastic. And of course, I'd like to acknowledge Artemis Diamantouros, who encouraged me to apply for this fellowship. Any questions or comments? Yeah.
What a fabulous project.
Thank you.
And you gave some examples of areas where for good reason. For example, what it was.
So the question was regarding what other types of minor ailments the medical directive would address. So I mentioned rash, minor rash, dyspepsia, oral thrush, topical yeast infections or vaginal yeast infections, sore throat. Sorry, I'm trying to think through all of them. There's a few. It's about 2 pages of medication, but those were the major ones. Thank you, Jerry. Yeah. So most of the pharmacists are actually my team. Yeah. Mhm. Yeah. So the question was about how other pharmacists on the team at Sunnybrook feel about this and if there's any extra training that's being done. So myself in particular, for the medical directive, I've done an extra accredited course through the Ontario Pharmacists Association about prescribing for minor ailments. It's also offered by the Canadian Pharmacists Association because other provinces have the ability to prescribe for minor ailments in the outpatient setting. So I'm doing that course, and if it were to be broadened to other surgical services and allow other pharmacists to do this, I would anticipate that they would also have to complete this course, potentially having a e-learning module that they have to do to check competency. Most of the other pharmacists I've spoken with are quite excited about this. I know the women and babies pharmacist would love to do this in her area. Some of the medicine pharmacists are looking forward to it as well. I don't know if it will carry over to that area, but within surgery, I think it would be a huge help.
Up next, we have Sarah from Michael Garron Hospital.
Hello, my name is Sarah Bingler. I'm an occupational therapist working at Michael Garron Hospital, and I'm here to present to you today on the quality improvement project that we are completing, focusing on improving the patient experience for patients with bariatric care needs at Michael Garron Hospital. So I'd like to begin by sharing with you a patient story. Mr. S. was a patient at Michael Garron Hospital this summer. He's a 73-year-old retired teacher who is admitted with pneumonia, and his weight at that time was 375 pounds. His baseline function at home was that he was able to get in and out of bed, on and off the wheelchair, and on and off the commode chair, with the assistance of one person, usually his personal support worker. He was also assisted with bathing, but he spent most of his day up on his electric scooter and assisted in the care of his elderly mother who has dementia. His experience in the hospital got off to a rocky start. He was very uncomfortable on the stretcher in the emergency room, which was too narrow to accommodate his body width, and he was unable to reposition himself during the time that he spent there. When he moved to the hospital ward, he was provided with a bariatric hospital bed, but the nurses didn't feel that they had the skills to get him out of bed, and as a result, he spent several days confined to bed in his room. He was referred for occupational therapy and physiotherapy assessment and intervention. We were able to develop a transfer strategy using the mechanical lift for the nursing staff, and in therapy sessions, we used a two-person standing pivot using a bariatric walker, and were able to get Mr. S out of bed. The challenge was that there was no chair available that was appropriate to Mr. S's needs. We were able to solve this problem by using Mr. S's personal scooter from home, which unfortunately had a flat tire, and I actually brought in my bicycle pump from home to pump up the tire. But going forward, he was able to spend some time every day up out of bed and in his chair, eating his meals in the chair, interacting with the staff, and experiencing the hospital like other patients would be able to. So we know that obesity is a progressive chronic disease affecting 1 in 4 adults in Canada, and this number is projected to rise. And despite this, healthcare facilities are frequently not equipped to meet the needs of patients with obesity. As a result, patients with obesity often avoid the healthcare system because of past negative experiences and safety concerns. Canadians with obesity face widespread weight-based bias and weight-based discrimination. They receive this from strangers, employers, educators, media, and even friends and family. And unfortunately, this extends to healthcare professionals as well, with negative attitudes thought to impact the quality of healthcare for individuals with obesity. When we talk about weight bias, this refers to negative attitudes and views about obesity and about people with obesity. Some examples are that people with obesity are non-compliant or lacking in self-control or lazy. And studies have even shown that some healthcare professionals prefer not to care for individuals with obesity, or when they're providing care, they avoid having physical contact with individuals with obesity. Weight bias results in anxiety, depression, and poor self-esteem for these individuals. And research shows that experiencing obesity bias increases morbidity and mortality for this population. So the occupational therapists at Michael Garron Hospital identified that there was an opportunity to improve, and they explored several factors affecting the care for patients with bariatric care needs at Michael Garron Hospital. I will review some of these. Some of the factors that were identified include there was no standardized process in place to identify patients who may have bariatric care needs on admission. We were frequently encountering issues with the availability and tracking of bariatric equipment, and the physical environment was often inadequate, with room sizes too small to accommodate equipment, staff, and patients, and doorway widths often too narrow to allow the transport of patients and/or equipment. Staff express a fear of injury, and also we acknowledge that staff have a knowledge deficit when it comes to population-specific transfers and handling skills, and bariatric equipment, selection, and operation. As discussed earlier, there is negative beliefs and attitudes towards people with obesity, which impact care within the hospital. The aim of this project is to achieve a 25% reduction in negative attitudes towards obesity among direct patient care staff working on the A3, B3 inpatient units at Michael Garron Hospital by March 2019. The quality improvement measures that I plan to use. I would like to start with patient experience interviews. I feel it's very important to use these qualitative interviews because it will allow patients to have a voice and give input into the intervention that is being developed and to humanize their experience for the staff. These interviews will be conducted with Michael Garron Hospital inpatients who weigh over 250 pounds. I will also be using the Attitude Towards Obese Persons scale, and this will be administered to direct care staff on target units, both before and after the intervention, to see whether there is any change in negative attitudes towards people with obesity. As a process measure, I will be tracking the number of staff who participate in education sessions. The current intervention that has been planned, which may be altered depending on the input from the patient interviews, are education sessions that consist of 3 components. First, what is obesity? What are some of the causes of obesity? Some common misconceptions about the factors contributing to obesity, with an emphasis on promoting small, sustainable health changes versus focusing on large changes in weight as an outcome measure for patients. Second, I will be talking about obesity bias, what is it, and the impact on patients and the healthcare system. The third component will be a video, a patient transfer video, which will model a patient-provider interaction. And I'm hoping that this video will give an opportunity for staff to explore their fears and anxiety when working with this population and begin the process of building transfer skills. Some of the early wins that I have experienced in completing this project is I've been lucky to have very good management support, and I've been given opportunities to share the message of the work that we're doing at a management forum and on the Michael Garron Hospital social media accounts. We are currently in the process of completing an equipment purchase of additional bariatric equipment. And as you can see, staff was very excited yesterday with the delivery of 2 new bariatric chairs. That is the level of excitement we experience when bariatric chairs are delivered. And I've already started to notice a culture change within the organization on the importance of addressing care for this population and improving the care that we provide. Road bumps. Initially, it was very challenging in terms of managing scope. As a group, the occupational therapists and I wanted to do a full staff transfers and handling program, but we had to acknowledge that within the scope and resources of this project, that probably wasn't feasible. And actually, addressing bias is a really good place to start and lays the foundation for the future improvements that we hope will follow. I'm still dealing with some red tape at the Michael Garron Research Department in getting the final research go ahead to complete my next steps, which are patient experience interviews and staff assessments, with the staff education sessions planned to go ahead in January. Cross our fingers. So in conclusion, the occupational therapists at Michael Garron Hospital are hoping that by addressing bias and talking about the patient experience, this quality improvement project will just be the first step in implementing a comprehensive bariatric care strategy at Michael Garron Hospital. I'd like to thank Michael Garron Hospital for allowing me to be the trailblazer and the first person to participate in this quality improvement fellowship. I feel very, very lucky, and it's been a great experience so far. Sunnybrook Practice-Based Research and Innovation, Catherine Vandenbush, Mary Forehand, Laura Istanbulian, and the occupational therapy team, who aren't here today, but are toiling away behind the scenes, Sandra Cowie, Shauna Funston, Nancy Jones, Jennifer Manoa, and Marilyn Wong. Thank you. Any questions? Sarah? Yeah, so the question is, are there best practices regarding bariatric care guidelines, or what other organizations are doing with regards to bariatric care? So I would consider this to be actually an emerging field nationally and probably even internationally. Some other countries, the United States, the UK, are probably a little bit ahead of us in Canada. There is a researcher who I've been very lucky to have contact with, Mary Forehand, who's probably the national leading researcher, Mary, as I said. She has been developing a set of comprehensive care guidelines with the team in Alberta, and she has been very nice to share some of those guidelines with myself. So it's very spotty. Some organizations have developed things, most organizations haven't. So this is really an opportunity for us to be leading the way in terms of hospital-based practice change.
project. Some staff had personal concern, fear that maybe they might be injured, maybe something. Yeah, were there any incident reports in that regard, or was it more a perception that you might?
For sure we know that especially nursing staff, the rate of injuries and back injuries are very, very high. As far as I'm aware, stats are not tabulated according to the type of patient that has been encountered. So they tabulate it according to the staff and the type of injury. We do know that from a physics point of view, there's greater weight load, and therefore there is an increased risk of injury. So from a science point of view, it is fair for staff to have a fear, and their physical abilities are their livelihood. So, these are certainly very valid concerns and concerns that deserve to be addressed. And that's why the focus will be on safe transfers and handling techniques and assistive devices that can make it safer.
I was also wondering, following through an incident with the hospital, this is rail down that the manager does, like what else could, and for a patient that might be heavy, healthcare workers. So maybe what could have been done, they asked for a or two more people. So that might have been the bottom line, or the lists that are there in place. That sort of thing. So possibly managers might recall baseline what caused this. It could well be that
Yeah, the comment is about, we always do incident reports afterwards, and there's always a manager review of those incident reports. And maybe when they do their own root cause analysis, maybe they are identifying the type of patient, and maybe there is an opportunity working with the occupational health and safety department to identify when there have been incidents that occurred specific to this population to allow targeted improvements in that area. And I think that's a really valid comment, and it's certainly worth going forward, making contact with the occupational health and safety department and bringing them in as partners to this project. Yes, thank you. Okay, thank you.
So we're back from the break, and our first speaker is Ruth from Sunnybrook.
Thank you, Sarah. My name is Ruth, everybody, and welcome back from break. My project is about improving patient discharge education, especially at discharge. I would like to start off by saying thank you to the GIM Brain and Innovation Fellowship for sponsoring this fellowship project. Also, thank you to Sunnybrook's Practice-Based Research and Innovation Fellowship. Thank you to Lois Billian, Tracy Dasgupta, who is my mentor, and also the Director for Interprofessional Practice. Thank you to Alicia, my manager, and also my amazing mentor. Thank you to Cynthia Woodard, who is my previous manager, but also a part of the reason why I'm here today. Finally, thank you to my V4, V5CU staff, who have been an amazing support towards this fellowship project. Recently, my sister actually had surgery, and before we left the hospital, the nurse came in, sat down with my sister and I, and gave us a really good health teaching. And even as a nurse, I found myself at home looking at the tool and going, you need to do this, you need to avoid this, you can't eat that. And I thought to myself, how much of this do I actually give to my patients when they are being discharged? I found the education so valuable that I reflected on my practice and thought, as a nursing student, providing discharge education was an expectation. But I graduated, I started working, and I forgot about it. But I thought I could do better. A little background, so we know that there's increasing readmission rates across the globe, and Sunnybrook is not an exception. Last year, there was approximately 8.8% readmission rates out here. We also know that the reasons why patients come back to the hospital is definitely multifaceted. There's so many factors. But what is also documented is that ineffective patient discharge education is a huge contributing factor. We all know that nurses spend the most amount of time with patients. So they are probably the ideal candidate to provide effective discharge education. But unfortunately, nurses are not making it a priority. My aim is therefore to implement, to develop and implement a patient discharge education tool that will be used by the nurses to provide effective discharge education to patients with COPD, pneumonia, and CHF. My goal is to increase the number of discharge education that's being provided by the nurses on B4 ICU by 50% between January and March 2019. A look into the literature is showing that there's increasing number of patients having to care for themselves at home. And we can all agree that right now we have patients in the hospital and we want them out as soon as possible. So they are having to do more for themselves at home. However, when they receive ineffective patient discharge education, it leads to the readmission rates that we have right now, and that might possibly influence the hallway patient situation we currently have as well. We also know that ineffective patient discharge education does not only lead to readmission, but also missed important follow-up appointments and medication errors at home. We also know that from research, when nurses are actually educated and their knowledge and skills is enhanced, they are able to provide effective discharge education that actually leads patients to verbalize a better understanding of their self-care after discharge. Education programs that have been developed and given to nurses actually do lead nurses to provide more education for patients. In order to have a better understanding of what was actually going on in my unit, I completed a chart audit. I wanted to verify if the need I have identified is actually a need. Looking at 36 charts over 22 days, I noticed that nurses on B4 are actually providing effective, good number of education. We can see here there was educational pulse, medications, safety, call bell use, and diet changes. And this is how it looks like on the graph form. We can see here what is missing is signs and symptoms, appointments, lifestyle changes, and resources. We can say that discharge education is the education provided at the end of the patient's stay in the hospital. And issues that need to be discussed include signs and symptoms, so patients will know when to come back to the hospital. Appointments they need to go to. Lifestyle changes, like don't drink too much water if you have CHF. But these are the issues that is missing in the discharge education provided by B4 nurses. To have a better understanding of how the staff actually feel about the project, and also to get their perspective and buy-in, I wanted them to feel involved in the actual project. I didn't want them to just see the end of the project, but actually see the whole process and feel involved and part of it, to see collaboration, because it wasn't just my goal, but it was the goal of the unit. So I conducted a focus group, and together we agreed that discharge education is important, but it's however limited on our unit. Also, we agreed that there's a need for formal education tools. This is an example of some of the comments that the nurses had. Discharge education is very important, but we do not do it because we don't have time. Also, the tool will help guide us on what actually we need to teach. In addition, to get a pre-assessment, pre-intervention data, I actually conducted a survey among staff, and I had a total of 54 responses, which is really great. I asked questions about their level of awareness, how important discharge education is, how often they actually provide discharge education, their level of confidence, and qualitatively, I asked if they do not provide education, what are the reasons, and if they had any comments to add. And this is what I found. We can see here, nurses say they are really aware of discharge education. Some are slightly aware, very few are extremely aware. When it comes to how important it is, we can see extremely important was the most selected option. Now we see it's very extremely important, but how often do they actually provide education? Sometimes was the most selected option, and rarely, surprisingly, was kind of high. Now when you compare how extremely it is important to how many times they actually provide education, we can see here it does not correlate, because something that's very important should be happening more often. You can compare this to vitals assessment. Sometimes we have patients who need Q1 hour vitals assessment, meaning every 1 hour their vitals have to be assessed. If you do a chart audit, you will notice that nurses actually do the vitals every 1 hour. Why? Because it's very important. They can see that it does help them make a life-saving decision. So they do actually do it. When it comes to education, we say it's extremely important. However, how many times are we doing it? Sometimes or rarely, right? It doesn't make sense. So what definitely nurses know that they need to provide the patient discharge education. But what's missing is the how and the why. And that's what my project aims to close that gap. I also asked about nurses' level of confidence. Surprisingly, most nurses are confident and slightly confident in providing discharge education. These are some of the barriers the nurses had identified as to why they do not provide education. There's no time. There's no formal tool or resource. There's limited knowledge on what to teach. And what I found really interesting was patient population. In medicine, most of our population is usually elderly, frail. There's language barriers. Some of them are nonverbal, especially on D4. But nurses are forgetting that there's caregivers who they can educate. There's family members they can educate. And it is really an assumption that an elderly patient does not understand the information. They might be elderly, but they might be very cognitive enough to actually comprehend a discharge information. These are my measures. I'm hoping that by the end of my project, I would see an increase in the number of discharge education that is being provided by the nurse from before. I would also like to see nurses demonstrate knowledge and ability and understanding of providing effective discharge education. I would want to see an increase in the patient's knowledge and understanding of their health, and hopefully to increase the satisfaction of patients in terms of our discharge process. My process measures will include the number of nursing staff completing an new learning module and number of staff attending in-services. These are my methods. I thought it was best to employ both qualitative and quantitative measures in order for this quality improvement project. So I conducted surveys, I did chart audits. I also actually did observation of nurses actually discharging patients, and I did patient interviews. For the purpose of time, I will not be discussing the results of observations and interviews, but I'm more than happy to discuss that after the presentation with anyone who's interested. My next steps. Currently, nurses will be required to complete an e-learning module on health literacy. So this gives nurses an opportunity to actually have an understanding of how limited health literacy is among the Canadian population. We assume they know about their health, but that's not the case. Nurses also have an opportunity to learn how to actually provide patient discharge education. They have an opportunity to practice it in a simulation-based environment. They learn how to use plain language in their discharge education to patients. What's most important is teach back principles. So checking for understanding, and that's a piece that's usually forgotten when people provide education. It's actually making sure patients actually understand the information you're giving to them. So nurses get to learn that principle. The tool that I will be introducing for nurses to use as a guide to provide education is called POTS. I've given each and every one of you a copy so you can look at it. This tool was developed by a group of people at UHN called Open Lab. They did an extensive patient research and determined, based on their research study, that the issues that patients would like discussed before they go home has to do with how they might feel and what they need to do. It goes into the signs and symptoms they need to look out for and how they need to resolve those issues. My favorite part of this tool is the emergency section. So nurses get to use this tool to teach patients that if you see these symptoms, this is indicating that you need to go back to the hospital. In this case, patients are not rushing back to emergency because they see a slight change in the temperature. They actually do realize that when you feel short of breath, then you need to come to emergency. On the flip side, for patients who avoid emergency situations, they don't want to come to the hospital, they stay home to their disease is really, really bad. They get to see that if they see these symptoms, really it's time to go to the hospital so they can get early treatment and prevent delaying treatment. The tool also goes into changes to my routine, which the nurse uses to then teach the patient that in case you're a CHF patient, you need to reduce your salt intake. It also goes into medication the patient needs to take and follow-up appointment that's needed. In conclusion, there's limited patient education, not just at Sunnybrook B4, but across the globe. We also know that patient discharge education is limited on B4, and there's a need to build a culture of patient education among nursing staff. Nurses need assistance in terms of increasing their awareness, knowledge, and skill to provide effective discharge education. In the end, I feel like nurses know the what, it's about how and why, which would increase the number of discharge education they actually provide to patients. In the end, we need to remember that better patient teaching does equal to safer transitions home. Thank you very much. Any questions? A checklist for the nurses to see what they've actually taught. Currently, that's not in the process, but it's something that we need to consider. But the way I have set it up is when nurses actually provide education, they will document that they have provided the education and they've given the tool to the patient.
As an occupational therapist, I often provide my own handouts in terms of where to get equipment or equipment types recommended. And I imagine patients get a lot of paper coming at them. Do you think there'll be a chance, even if not in the initial rollout, but for other staff to be able to integrate some of their recommendations into one whole document?
That's definitely a possibility, and it's a good idea because there's definitely interprofessionals when it comes to patient discharge. There's dietitian, there's nutritionist, there's OTPT. So it's definitely something that we can incorporate. Yeah. So currently, I believe that we're starting on B4, but if successful, definitely we will roll it out to other units. And the plan is to develop each tool for each specific condition. So it's not one tool for all because every patient has a different experience and there's so many different conditions. So that's definitely in the plan eventually.
Development of a patient brochure. And what changes do you make on this the project?
So the domains of the tool is based on the research that was done by Open Lab. So in terms of changes to my routine, medications, follow-up appointments, how I might feel and what to do, those are the domains from what was developed by Open Lab, but the content was developed by myself and a group of other health professionals here at Sunnybrook. So the content itself, we put it together and it was reviewed by doctors and patient partners and individuals who deal with plain language. So it's not, because a lot of discharge summaries have terminologies that patients do not understand. So we plan to make this easily understood by patients. Yeah.
So it sounds like you use the same framework.
Yes, the domains are the same.
Great. For the Sunnybrook my church, you know if
Yeah, it's interesting you said that because I did present on my interview with patients, but I actually did interview patients, and that was one comment that came up. Patients have said, well, I would be happy to take this tool home, but what if I lose the paper? So it was a good comment, and they did suggest, well, if it's part of my chart, they could always log in and see it. So I have definitely brought that to my team of PODS implementation. So that's something that we plan to eventually roll out. And also we plan to include that into the discharge. I don't know how the discharge process works in the computer for the doctors, but we plan to include that so that when they go to print the discharge summary and prescription, it automatically prints with it, with those two documents.
So up next, we have Angela from Sunnybrook.
Hi everyone, thank you for giving me the opportunity to present my fellowship project today. My name is Angela Turner. I'm a radiation therapist at the Odette Cancer Center. And I apologize for the long title, but this is my project, Make Every Conversation Count, supporting radiation therapists' clinical responses to sexual health issues of prostate cancer patients receiving radiation therapy at the Odette Cancer Center. So I want to start my presentation by sharing this comment and this story from a prostate patient that I met in a follow-up clinic when I was working up there, and just talking to prostate patients about information that they had received around sexual health issues and who had given them the information, was it useful to them. And I met this patient and he had had surgery for his prostate cancer. And he told me that he didn't remember receiving any information at all related to sexual health. And then after his surgery, a while later, he had problems with erectile dysfunction. And he didn't connect it to his surgery, and he really didn't understand why it was happening. And this is what he said to me. He said, it wouldn't have mattered when I got the information because I would have had the treatment anyhow. But it would have been good to be more prepared about what was going to happen so that it wasn't a surprise. I asked myself this as well, what next? What else haven't they told me about? And what he explained to me was that he, because of his experience, he had lost all confidence in his healthcare team, and he really didn't trust them anymore because he didn't know what else they had kept from him. And it meant that he was in a constant state of anxiety about what was going to happen. And so after this conversation with the patient, which was really about what information did you get, it started me thinking, well, what happens when patients don't get the information or they don't remember it anyway? Like, what's the impact of that? So some background for people that are not involved in cancer care. Cancer Care Ontario is a government agency which was set up to monitor and improve cancer services in the province. And in Ontario, all cancer patients who attend regional cancer centres complete, or they're requested to complete, symptom screening questionnaires prior to their visit or their treatment. And symptom screening data and screening rates are one of the quality indicators for cancer services in the province of Ontario. So in 2017, the Odette Cancer Centre initiated a specific symptom screening questionnaire for prostate cancer patients, which was mandated by Cancer Care Ontario. And up till that time, the symptom screening was a general questionnaire. On the specific symptom screening questionnaire for prostate patients, there are 3 questions which are specifically related to sexual health issues, related to erectile function, orgasms, and just general quality of sex life. And at the time of the rollout, there was a needs assessment with Odette Cancer Centre staff, looking at what were their needs and training needs for the rollout of the symptom screening, and sexual health was identified as the topic which staff had the lowest comfort level and knowledge around. And after the rollout, there were some chart audits that took place and some anecdotal evidence and feedback from staff which suggested that the sexual health scores were not being addressed by the healthcare team. And this is some data from Cancer Care Ontario from their patient experience survey. And they actually asked patients if their healthcare team talked to them about their symptoms of concern. And you can see that about 50% of patients say that they always do. So you might be thinking to yourself, well, is this really a big issue, and is it a real problem for patients? And again, this data is from Cancer Care Ontario, and it talks about the burden of sexual health issues for cancer patients and sexual health related distress. And it talks about not just the patients themselves, but you can see at the bottom there, the majority of partners of prostate cancer patients also report significant distress. So this is an issue that doesn't just affect patients, but also their partners as well, potentially. So this led me onto my fellowship project, which is to support radiation therapists at the Odette Cancer Centre to engage in the clinical response to the sexual health scores identified through routine symptom screening process. And my aim is that by March 2019, the radiation therapists will respond to 40% of the sexual health scores reported through the symptom screening process. So some of the methods that I've used for my project, I did a chart audit of prostate patients' records and looked at 20 patients prior to doing any interventions at all. And of the 20 patients' charts that I looked at, 12 of them had completed the symptom screening, 9 of them had high sexual health scores, and there was one documented response to those scores. It was very general, nothing specific about the individual questions. And that response was by a radiation therapist. So my idea for the project was to really develop some training and education to increase the confidence level of radiation therapists and their awareness of resources. So I developed some training sessions and KT sessions, and before I did that, or as part of that process, I asked the radiation therapists who would be involved to rank in order of importance what they really needed in order to respond to the scores. And so these were the topics that I asked them about, and it was somewhat led by the questions themselves. So did they want knowledge about starting conversations, quality of sex life, sexual health resources, erectile function, orgasms, or the documentation of their sexual health discussions? And this is what they said was important to them. So starting conversations was the number one issue that they had a problem with. So my progress to date is that I have conducted 3 training or KT sessions with 10 radiation therapy participants. And I would say that those sessions, which I'll discuss later, but didn't quite go according to plan. So I would say that those were pilot sessions where really I did get a lot of discussion and collected a lot of interesting and informative data. But the general feedback from the sessions were that it did increase the radiation therapist's knowledge, and it did make them more aware of resources that were available to patients. So using the PDSA cycle, which we've learned about during the fellowship, I, as I said, want to utilize the data that I have got back from those 3 initial training sessions. And one of the things I asked the therapist was, would you like a scripted response that you could use with patients? patients, and 100% of them said yes, they would. And they would also like a specific template for documentation. So my next steps really are to create those scripted responses which can be practiced and utilized in the clinical practice of radiation therapists, and to develop the standardized templates, and also to standardize the training process, because it was very tailored to the individual therapists that were at the sessions, but I realized going forward that that just is not a feasible process. It's too resource intensive. So once I develop the scripts, I will have them reviewed and revised so that they can be approved by the radiation therapists and make them acceptable for them to use. And we have a documentation group who can review and revise the standardized templates, collate all of the resources and materials that we have, because that was one of the issues. People didn't really know what was available for patients, and also how could they readily access them. And then my plan is to conduct chart audits again on 20 patients to see if there has been any change with the response. So like I said, some of the lessons I've learned, I wouldn't say that my project has gone according to my original plan that I had, because I've had to adapt things to real life, as I think everyone here would agree with. And I also have realized, and it's been made very clear, that tools and processes have to be developed so that the project can be sustainable going forward. And I'd like to acknowledge my mentors, Karen Ferguson, Danny Westbury, and my practice leader, Laura Delamonte, who's always there if I need any help with anything at all. And Steve Russell, my manager, and of course the TASHNp Fellowship for the funding that they provide to all of us to do these projects, which is very important. Thank you. Does anyone have any questions? Lisa?
Other different sites. I know we think about the prostate cancer patients, but it must affect everybody, especially with.
Yes. Lisa's question was about other disease sites. And yes, I think that's always something that we discuss as radiation therapists, and people always say to me, why do you focus on prostate cancer patients? Because they probably are one of the groups that receive the most information, although not that much. But I think the thing about my project was that I needed a group where there was some data that I could use and compare going forward. So we really don't have a lot of data, documented data from the other sites about information they receive and support that they have. So for this project, I wouldn't have been able to monitor, any improvements or changes. But I think going forward, yes, it would be good once we get the process and the tools in place for prostate cancer patients to go forward with the other disease types. Thank you. Thank you, Angela.
So next we have Joanna from University Health.
Thank you, Sarah. I'd just like to start by thanking everyone for coming here today, and also those who are tuning in. Before I start, I would like everyone to close their eyes for a moment. Can you picture yourself sick with organ failure, and uncertain if you will ever make it to the top of the transplant list. How would you cope with the physical and emotional suffering of living with end-stage organ failure? And when you do get your transplant, is all your stress alleviated? Imagine if we could empower patients and families to access support and services that are available to them to help them manage the burden of transplant. At UHN, the transplant psychosocial team provides assessment and support to organ transplant patients both before and after their transplant. So today, the outline, I'm going to go over the current state, needs assessment, the focus group, aim statement and measures, the PDSA cycle, next steps for my project, and lessons learned. So at UHN, our transplant program is growing exponentially. Last year, in 2017, we were the highest number of transplants in North America. This has resulted in an increased demand for psychosocial care and management of both pre- and post-transplant patients. Transplant patients can face unique challenges, including living with pre-existing psychiatric conditions, delirium, addictions, managing the neuropsychiatric side effects of immunosuppressant medications, and guilt around receiving an organ. Currently, there is a lack of psychosocial focused educational resources for our transplant patients and their families. In my clinical experience, I've noticed that patients that have been referred to me often tell me, "Why didn't I know you existed? It would have been helpful for me to see you earlier." So for my needs assessment, I conducted a literature search. This search essentially has found that there are not a lot of resources in terms of material or studies that have been done around interventions pre- and post-transplant. The literature also does validate that the transplant experience is very challenging and difficult for patients, and a lot of the interventions tend to be focused on pre-transplant patients. For our service, for psychiatry and mental health nurses, we see an average of 17 referrals per week. An environmental scan of the patient education resources at UHN has found that there are some books available for transplant patients. However, they are actually not being taken out and used by patients. In addition, a lot of the books are a little bit out of date. Also looking at other transplant centers across Canada and some major centers across the US has found that there actually isn't any written material targeted for patients and their families. I also did a conference call with Alberta Health Sciences, which is a very large transplant center as well, and they actually also do not have any written resources for patients. I did find there is a lung transplant support manual. However, that is very out of date and is often actually not used by patients. I also did meetings with stakeholders, patients, psychosocial team coordinators, physicians, and spiritual care, and it was all agreed that there was a need for this service. Actually, a lot of people were quite surprised that despite the presence of the psychosocial team with the transplant program, that there wasn't anything available for patients. So the patient partner focus group I conducted was to help to get a sense of what the patient's needs were, what their experiences were, what kind of content and material that they thought would be needed, and also the format. So during the focus group, we talked about the psychosocial resources access. There were some patients that had access, some patients didn't, some patients had no clue it existed. In terms of the educational material and the content of it, a lot of them, one of the big aspects was talking about the side effects of immunosuppressant medications, particularly on their emotional well-being, and the impact of lifestyle changes on their life, and also just making sure that patients are aware about the supports available to patients, both within UHN and also outside. In terms of the format, they preferred both written and online and digital. So to have it being able to access online and also written would be important for them. And also what came about is that the transplant manuals that are available should be updated to include some psychosocial material as well. And in terms of raising awareness, they thought that having posters, brochures, getting their coordinator to talk to them, and using EasyCall, which is a telephone messaging system to communicate with post-transplant patients, should also be used to let them know about the service. And here, this cloud is results of the emotional mapping exercise that I did with the patients. I asked them to talk about their various emotions that they experienced throughout their transplant journey. As you can know, one of the biggest experiences that they all shared was having hope. And I think this is really inspiring and something that we should draw on. So the aim statement for my project is by March 15th, there will be an increase of 15% in transplant patients who are aware of the transplant psychosocial resources that are available to them. The outcome measures that will be used is having transplant patients' awareness being measured in pre and post patient surveys, and also transplant patient satisfaction of the interventions being measured post-survey. The process measures, which again are also informed by the information retrieved by patients during the focus group, is the number of patients who were sent an EasyCall to inform them of the new psychosocial resources, the number of brochures taken from the walls and handed out by pre-transplant coordinators, and also website metrics of the transplant mental health team webpage that will be tracked on the UHN transplant website. So part of the project will also be to create a webpage specific on the UHN transplant website. Balancing measures will include post-intervention staff surveys via SurveyMonkey, and also to track the number of referrals to mental health nurses and the transplant psychiatrists. So in terms of the PDSA cycle, it's sort of twofold. The first is to develop the patient education material. So the first that has been done is the focus group. I've already drafted the patient education material, which will likely look like a booklet or a pamphlet, and then receiving mentioned feedback and also feedback from the psychosocial. So this would include the transplant psychiatrist, the nurse coordinators, the nurse practitioner, spiritual care, and social work. And what I'm waiting for, hopefully by the end of this week, is to submit the draft to patient education for readability and the review. And after that is done, then to review, of course, with the patient partners to get their feedback. The other part is to do the surveys around awareness. So the first step for me was to submit to RIB, and that happened on November the 6th. I got my RIB waiver on the 21st and went through various drafts of the patient survey. And the first round of patient surveys was out actually starting today. Will be the first draft, the first round of surveys. So I'm hoping to collect about 1 to 200 surveys, but we'll see how that goes. So next steps for the project is to gather 100 pre-intervention patient surveys from the 12 PMB ambulatory clinics, submit the draft of coping with a transplant to the patient education department for review and analyze the initial survey feedback, and start to create the psychosocial transplant webpage on the UHN transplant program website. So the lessons learned is that there is a lack of patient education material on coping with the transplant, despite a body of evidence and presence of psychosocial teams embedded in the transplant center. I did find this really surprising because of how embedded this is, and that I really thought that I would be able to find something beyond our program. The other lesson was co-facilitating a focus group. It was really fun, and it was also interesting to try to gather the feedback and the information that you needed. One of the really key learnings too was patients do not like the terms psychiatric, psychosocial, psychoeducational, or even mental health. And when we brainstormed some sort of words, and coping seemed like the best sort of fit. And I do agree, because it does sort of acknowledge that there is something that they need to cope with, a stressor, but it also acknowledges a positive part and also how to move forward from that. Also, the collaboration with patient and family libraries, there was a lot of information that was there that I didn't know it actually existed, and I'm sure many other people don't. So a lot of it is about collating what's available at UHN, including other brochures that might be relevant. For example, they have brochures around anxiety, depression, stress reduction. So instead of reinventing the wheel. It's to sort of gather everything and have it in one place so that people can access more readily. And also the need for confirming timelines in advance. There will always be delays. The one roadblock or delay that I found was that when I spoke to patient education, that it would likely take about 11 weeks for the brochure to be done. So the solution that we're likely to come up with is to create, have a brochure ready for the purpose of the project, and then hopefully when that other brochure is what we'll use long-standing for the program. And with that, it's also around being patient and enjoying the process. Sometimes that we get really focused on what our outcome is going to be and what we have to do with deadlines, but really this is about learning about quality improvement and learning the system and learning from our mistakes. So I'd like to acknowledge the Joey and Toby Tannenbaum Fellowship for funding my fellowship, the collaborative academic practice and the facilitators, Rhonda Allen, Sarah Moresi, Sarah McMillan, and special thanks to the UHN patient partners for having such a robust discussion and their passion to helping improve the transplant program. Of course, to patient education and the family library, the transplant psychosocial team, and the ambulatory transplant coordinators and clinic staff. Thank you so much. So the question was around this individual works on respirology floor, and there are pre-lung transplant patients that often come to their unit. And if this intervention is going to support, or is there a plan to support? So thank you so much for your question. The intervention is actually around pre and post-transplant patients. So it will be looking at developing both. So my hope is when this brochure pamphlet is done, that I would also be providing it and making sure the staff on the units throughout UHN who are not necessarily the transplant program, but do have pre-transplant patients such as respirology, the ICUs, cardiology, the liver clinics, that they'll be aware of this and they can provide that to patients. Thank you.
It's something that's living or other things.
Yes. So the question was around that there might be some stress or burden for patients in terms of living with a donating organ and their thoughts and feelings towards that, and is this sort of incorporated into it? So yes, thank you for your question. I didn't get the opportunity to show you my draft of the Coping with Transplant brochure, but it certainly does talk about sometimes people feel a bit of guilt, both before waiting for a transplant, or in terms of waiting for an organ, and also after transplant in terms of living with deceased organ and thinking about where the organ came from. So that's definitely some patients have that experience, and we do sort of talk about that. Often what we do tell patients is that people die every day, and families who donate organs, their loved ones' organs, often it's sort of a glimmer of sort of joy and a sense of that their loss can actually help somebody, and that's often the conversations we have with patients. So certainly that is a very important aspect around coping with the stress.
Yeah, your presentation was really good, and I was thinking when you were discussing the focus group that even the process of participating in the focus group must have been somewhat therapeutic for the participants. Has your service looked at, or are there any opportunities to use like a peer support or group support model?
So yes, actually our program, we did have a mentor program before, and I think all of our staff, thank you so much for bringing that up, because I think all of our staff and our patients have expressed that that would be very important to have some sort of peer support, mentorship support, and hopefully that's something that we can look at through creating. After I had that conference call with the Alberta social workers, they actually have a coping skills group where they have patients and they teach them some skills, but it's also informally a way for them to connect with each other. And hopefully in the future, we'll look at doing something like that here as well. But certainly we do acknowledge that there is such a therapeutic sort of, effect of having people together and sharing their experience.
Thank you, Joanna. So up next we have Lauren from nursing.
Thank you, Sarah. And thanks to everyone for coming to hear about my project on patient goals of the drivers of care in brain injury rehab. I'm Lauren. I'm one of the occupational therapists from the inpatient acquired brain injury unit at Toronto Rehab. I'm excited to share with you guys what I've done for my project so far and where I intend to go. So before we delve into talking about my project, I just wanted to challenge all of you to think about a time where you had to set a goal for yourself. So what comes to mind is a New Year's resolution, which will be coming up soon, thinking about a career aspiration, perhaps going to the gym more, eating better. And just, when I reflect on my experiences setting goals, it's challenging. And I think more so than the challenges that I've had setting longer term goals, it's really being able to break down those long-term goals into shorter, achievable stepping stones that will help us to achieve our longer term goals. Similarly, for the patients I work with on the acquired brain injury unit, it's difficult for them to set goals, and we're asking them to do this sometimes on day 3 of their admission. And even more difficult is it for them to break that goal apart and really figure out how to navigate the rehab journey. So, our patients really require the support of an interprofessional team to get them through this process. So just to provide some background, so the Ontario Neurotrauma Foundation states that for patients with a brain injury, goals should be set early during the course of rehab and monitored regularly. The literature shows that patients achieve better functional outcomes, especially when these goals are meaningful, personally relevant, and the patient and family are involved in the goal setting process. The literature also shows that goal setting contributes to better interprofessional communication and collaboration. I was very fortunate back in November of 2017 to be a part and sit in on one of our real-time patient advisory groups on the topic of goal setting and goal use for our inpatient acquired brain injury patients. In this group, we had the opportunity to hear from 11 current patients at the time, as well as 3 caregivers around their experience with setting goals within the program and how the team uses their goals throughout the rehab journey. Our patients had a lot to say, and what was crystal clear to me was how important it is for our patients to have these goals to guide them, in a time of despair, in a time where they're looking to really, have hope and make changes and get back to their lives. And so a lot of the things that came out of this group are things that we're taking into consideration and planning our intervention. Over the past few years, recognizing how important it is in the literature and best practice that our patients have goals that guide their rehab journeys, and hearing directly from our patients' voices how absolutely important it is that they have goals, I definitely was able to take a step back and recognize a gap in our program and service delivery. And that's really what inspired me to take on this project. So I'm very, very fortunate to work on a unit and work on a program where quality improvement is central to everything that we do. At any given time, there are a number of quality improvement initiatives going on, and I've been able to see some of them be incredibly successful and others not have that same success and sustainability. And for me, when I reflect on that, I think a big part of what makes a quality improvement sustainable in my particular program is having that frontline engagement right from the beginning. So when I was accepted to the TASHNp Innovation Fellowship, for me, the first step was to put together a working group, because in order for me to make this project sustainable, I knew what I had to do on my particular unit. I was blown away by the sheer interest in people joining this working group. So I had anticipated having a small steering committee, 5 or 6 people, and it turns out we have a working group of about 16. I did not want to turn anyone away, because as part of my engagement plan, I really wanted to make sure that everyone felt as though their voices were being captured throughout the process. We're very fortunate to have representatives from all of allied health, nursing, medicine, management, service coordinators, and very, very fortunate to have 2 patient partners who are instrumental in the co-design of all of the intervention that's happening. So the first thing that I do once I put my working group together is really try to understand the problem. I think, it's so important in developing a robust quality improvement project. So just so you guys are aware of the current process on our unit, so when a patient's admitted to the program, a goal coordinator is assigned. This goal coordinator, within the first few days to week of admission, elicits goals from the patient and their family if appropriate. We do have interprofessional care planning rounds that happen once a week for 1.5 hours to 2 hours. We're very fortunate to have that time. During those rounds, the patient's goals are read aloud. However, at this time, they don't guide our discussion and collaboration. So the way that we give our updates in care planning rounds is very profession specific. Toward discharge, we do write the goals, our patient's goals, on the discharge transfer summary, and the patient as discharged. So as you guys can see from our process map, there's a pretty big gap between setting a patient's goals and really how we're using them as an interprofessional team to guide our patients' care throughout their rehab journey. I'm having a hard time with this. So once we really figured out the problem, so the problem being that we do set goals with our patients, for 80% of our patients we set goals, and some of the data I collected, as an interprofessional team, we're not really using them throughout a patient's rehab journey. So a pretty big problem. It was important to me to guide the working group in a fishbone diagram. So essentially this was to help us, those of you who don't know, to help us figure out the root causes of the problem. This was particularly important just because this is a huge problem that affects so many different aspects, and I wanted to make sure that, as a working group, we were really dedicating our energy and time to creating a change that would have a huge impact on the actual problem that we identified. So from this fishbone diagram, we were able to essentially come up with 6 main themes or 6 main root causes. Lots of the different ideas overlapped. 2 of them were things that were out of our control, so we put those to the side. And from the 4 remaining root causes, we actually took the time to plot them onto an impact effort matrix. So essentially this is just looking at, plotting the different ideas and figuring out how we can have the greatest impact with the least amount of effort. Not to say that that what we ended up choosing has a small amount of effort at all, but certainly thinking about the feasibility within a short time frame and really having the greatest impact on our patients and on the team. So what we ended up deciding on is the focus of the project is really looking at redesigning our interprofessional care planning rounds to enhance team communication and collaboration toward patient goals. So moving away from the more profession-specific updates to really having our patients' goals as front and center to the discussion we're having to guide our patients' care planning. So we did a lot of work, but we finally were able to land on an aim statement. So the aim statement is by March 2019, 50% of patients will have at least one patient and or family identified goal discussed collaboratively at interprofessional care planning rounds on the inpatient acquired brain injury unit at Toronto Rehab. So how will we know that the change that we implement is successful? So the outcome measure that we'll be tracking is the percentage of patients that have at least one goal discussed by more than 2 clinicians. And that's how we decided to define interprofessional collaboration for the purposes of this project. Some of the process measures that we'll be tracking which are essential to achieve our outcome measure and our aim statement, the percentage of patients with established goals, the percentage of patients with goal-led discussions in care planning rounds, and of course there'll have to be an element of education to staff about the new care planning rounds process, so looking at the number of staff who attend that. So of course, always thinking about the balancing measures, so things that are, unintended consequences, both positive and negative. So one, of course, is the length of interprofessional care planning rounds, because that can, of course, be affected. So we'll track that. I've also done a patient and staff survey to look at both the patient's perception of their perception of the use of goals to drive their care, and also staff perception of collaboration by patient goal and care planning rounds. So, I'm very, very fortunate to be a part of this TASHNp Innovation Fellowship, and of course have learned a lot about quality improvement and the process, but I think, equally as important, maybe even more important, are the lessons that I will take with me to help guide how I work on any future projects and of course in my future career. So the first thing that that's resonated with me is the importance of a strong engagement plan. So I've touched on this a little bit with the establishment of my working group, but I think you can really, really see the passion and the energy amongst the entire team, just with so many people having their voices heard. In addition to having the working group, I've taken the time to meet with many different staff members to just ensure that even though they're not sitting on the working group, that they also feel as though they're a part of this process. And just a funny story to share, but a couple of weeks ago, a few of my colleagues went out for dinner, and they came back the next day, and I had asked them how dinner was, and their response was that they spent quite a chunk of the dinner talking about goal setting and goal use and how we can improve this project. So it made me really proud just to think that, I'm not the only one that has this passion and excitement for the project, but it's really resonating in the program and on the floor. Another thing I learned is that a lot of us share the same ideas. So in my staff survey, there were some quantitative questions as well as qualitative questions. And one of the questions looked at what we do well and what we can be doing better as a team to help support our patients' goals. And I would say the majority of clinicians share that changing the way that we discuss our patients' progress throughout the rehab journey and having goals as the central care planning rounds is an idea that was shared by the majority of staff. And it surprised me because it's not something we've ever discussed as a larger team. And I think it made me think about having these conversations about what our ideas are for quality improvement, because if the energy and the passion is there, I think there's a lot that we can do. And the last big thing is just really the benefit of these quality improvement tools. So I'm a very solution-focused person, and I think had I done this project a year ago, my intervention plan likely would have been quite different than what it looks like now, really having taken the time to go through a lot of these process mapping and fishbone diagram and impact effort matrix. So certainly see a value with that, and I'm hoping to slow down when it comes to thinking of solutions. So next step, throughout the month of December, I'll be leading the working group using an appreciative inquiry approach to guide intervention design. We've already started, and it's been a really exciting process, so we'll see how that goes over the next month. We'll also be looking at planning some preliminary PDSA cycles, which will hopefully start in January 2019. And of course, as always, continuing to develop our sustainability plan. Want to make sure that this sticks and this works and it spreads. So really looking forward to that. So in conclusion, I'm really, really hopeful that changing the way that we as an interprofessional team communicate and collaborate toward our patients' goals is the stepping stone to really making our patients' goals front and center to everything we do, and giving our patients even more of a voice to guide every single step of their rehab journey. So I just wanted to thank the Department of Collaborative Academic Practice, my incredibly supportive mentors, Angie and Edith, my manager, Allison Freeman, and of course, all of my working group members, where there's no room on the slide to list all of them, but really, really grateful for all the support so far in this project. Thank you.
I know working as an OT in acute care, sometimes we're frequently not very patient-centered because we're very driven by length of stay. Is that a pressure that's come up during your conversations about how how to balance resource utilization and wanting to be patient-centered and allow patients to drive with the goals of their rehabilitation?
That's a really good question. So just that's what everyone can hear. The question was really around balancing the pressures between using resources wisely, so getting patients out of the hospital and being patient-centered. And definitely, you know, it is always a concern. I think we're very fortunate in rehab that there really is a huge focus on patient-centeredness, patient engagement, the patient experience. So of course, we have targeted length of stays that we do need to meet, but I think we have an incredibly supportive management team that, you know, feels as much as we do that patient-centeredness is key. We know that better patient outcomes are achieved when we are patient-centered in rehab. And so I think it's a balance. I think there are certainly things that we have to do as an interprofessional team to help our patients get out of the hospital and get home. But I think a lot of that, you know, if we're creative as clinicians, I think there's a way to make those two things match up. So, you know, if our patient's goal is really big and they want to get back to work, and of course that's not going to be able to be achieved within, you know, a 4 to 6 week length of stay, it's really looking at breaking that down and figuring out, well, to be able to go to work, you have to be able to get yourself out of the house, find your way to work. So things that are necessary for discharge. So I think it takes a lot of creativity, but I think there is a way to balance it. Yeah, thank you. Yes.
Great job.
Thank you. Mm-hmm.
I wanted to ask you by an example, at least 3 health professionals involved.
That's a great question. So the question was just around providing an example of an opportunity where 3 or 2 or more professionals work toward a patient goal. So one of my most memorable patient situations, so I can speak to that as an example, is a patient whose goal was to be able to go to McDonald's. Like that was his goal for rehab. That's a good goal. No judgment. But essentially, so what we did, so literally we had a collaborative session where myself, the physiotherapist, and the speech therapist accompanied this patient to McDonald's. And so the physiotherapist was, of course, looking at community navigation, you know, physically how they're going to manage getting to McDonald's. I was looking at more wayfinding to McDonald's, safety, you know, the cognitive processes, and the speech therapist was looking more so at how this patient was able to communicate and order their meal. And so, yeah, like I said, I'm very fortunate to work with such a creative team, but there are certainly lots of ways that we can work together to help our patients achieve their goals. Thank you. All right, thanks guys.
Okay. And up next, last but not least, we have Laura from Mercy Health Network.
Ground floor, green zone desk. Your attention please. Code white, A, alpha wing, ground, green zone desk.
Hi, good afternoon. My name is Laura Richards, and I'm a nurse at the Gynae Clinic at Princess Margaret Cancer Center. And my presentation today is about improving care transitions for gynecologic oncology patients from having their surgery at Toronto General to adjuvant chemotherapy at Princess Margaret. First, I'd just like to take a moment to acknowledge everyone who's been there to help me and support me thus far in the program. So first and foremost, the collaborative academic practice, the nursing fellowship through UHN, but of course my mentors, Dr. Stéphane Laframboise and Shanaz Dalla, not to mention the patients and UHN patient partners, and last but not least, all the supportive department staff and leadership and management across both sites. This is just an outline of what I'm hoping to speak with you about today. So starting with the background, so again, I'm a nurse currently employed at Princess Margaret in the Gynecologic Oncology Clinic, ambulatory care. But previous to that, I was an inpatient nurse at Toronto General, still caring for the same patient population, our gynae oncology patients. So I can offer a unique perspective having seen both sides. So I thought I'd lead in today by just sharing some patient quotes that I routinely hear from our patients. And the themes are, "This is too much too soon," "information overload," and "I haven't even digested my diagnosis yet. I'm still recuperating from my surgery. And now you're talking to me about chemotherapy and all these side effects?" So I thought we could start by just looking at the current state and identifying why our patients might be feeling this way. So I do have a current state process map, but I can appreciate it's very small and might be hard to follow. So I have made a poster board to help illustrate the care trajectory for these patients. So you'll notice that each panel illustrates 1 week of time. But I'll also mention that all the teal areas occur at Princess Margaret. The black areas are while the patient is at home. The yellow areas occur at Toronto General Hospital. And also noting that the bottom of the poster board is the current state. So my apologies to those on webinar, but for those people that are here in person, follow along. Starting with the bottom, it's a new patient to Princess Margaret. And one of the first questions asked when they see the gynecologic oncologist is this patient a surgical candidate? And this would be based on the patient's disease itself, as well as the patient's past medical history. If they are a good candidate for surgery, they sign consent for surgery at Toronto General that same visit, that same day. They then go home for 2 weeks. And then about week 4, they're seen at Toronto General in the pre-admit, sorry, I should be pointing to the bottom, the pre-admit department for the surgical workup. The following week, they have their surgery and are discharged home, and then they're home for about 3 weeks before we see them back at Princess Margaret for the post-op clinic visit. And it's at this visit there's another decision to be made as to whether, based on their final surgical pathology, if it's recommended that they have adjuvant chemotherapy. And if it is with that recommendation, they attend a group gynae-specific chemo class. It's offered at Elixir at Toronto General Hospital every Friday. So they'd be attending that same Friday, and then they proceed to chemotherapy the very next week. So it's the case with a lot of our patients that they attend chemotherapy class on Friday and start treatment as early as Monday or Tuesday the following week. You can appreciate why the patients are feeling so overwhelmed. So the aim of my fellowship is to increase patient satisfaction with the information they've received by 10% by the end of this CAP fellowship in March of 2019. And I intend to measure it with pre and post surveys. So surveys to patients who have already been through this treatment trajectory and compared to patients that might be starting during our change state. And so we're looking at the process to be that I would be reviewing the OR lists for the week with all the surgeons, and they would help identify patients who are known, if they're known that they're going to need chemotherapy after or have a high likelihood to need chemotherapy after, so I can follow them with surveys or interviews as well. So for my needs assessment, I was fortunate enough to have a focus group of 2 UHN patient partners. And some of the themes from the focus group, barriers-wise, was that they both mentioned that cancer incapacitates you. And so it's hard to retain any information after that diagnosis. So when they're seen in clinic post-surgery and they get the confirmed diagnosis of cancer, it's really hard to retain any information offered in the chemo class the Friday following. They also mentioned areas to improve would be, as in a lot of things, communication, communication, communication. They verbalized that if it's known to the surgeon that there is that high likelihood that they'll need chemo after, that they want to know earlier, before they're seen 3 weeks post-operatively, to start chemotherapy treatment in less than a week. They also mentioned continuity of care. They're across many sites in a relatively short time frame. They're meeting a lot of people. And as one patient partner put it, if I could have just had one go-to person that I could ask my questions of, it really would have helped alleviate a lot of the stress and anxiety I felt. So some of their ideas did include more chemotherapy education. And in an ideal world, this meant to them that it would be one-to-one nurse-to-patient chemo education. So after the focus group, I did administer baseline surveys to patients that were seen in follow-up in clinic who, again, have been through this treatment trajectory before. I had 23 surveys, and the results were interesting in that they gave us really, really high satisfaction rates, 8 to 10 out of 10, almost across the board. But that when they were asked open-ended questions, a lot of them had a lot to say. And so I just brought, they're all anonymous. I just brought a few here, which you can see in the audience as well. You can see, sure, I'll just show the webinar people as well. Maybe it doesn't reflect so well, but there are a lot of free text down the margins of the page. So even though they're giving us really, really high satisfaction rates, they're also at the same time giving us many areas we could improve upon. So some of the interesting stats from my surveys, again, out of 23 patients surveyed, 30%, almost 1/3 of the patients could not attend the group gynae chemo class. Could be a multitude of factors. There's other things maybe going on in their lives or other appointments, but they were unable to attend the chemo class that followed their clinic visit that Friday. 38% felt only somewhat prepared going into chemotherapy. And 43% agreed that the best time for chemo education would be somewhere between the initial consult and discharge from hospital. So again, meaning by the time they're seen in clinic post-op, it's already a little too late. And that 43% just seems even bigger when you factor in that 22% of patients were not sure when the best time would be for education around chemotherapy. 31% of patients reported information overload at chemotherapy class, and 44% said it would have been helpful to have more time between the chemo class and starting chemo, because again, as it stands right now, it could be less than a week time interval. So literature supports this project by validating the tight time frame that Princess Margaret has. The optimal time to receive chemotherapy after surgery is known to be 21 to 35 days. And because we strive to be in that window of time, that's why there is such a tight time crunch on the process map.
Attention please, may I have your attention please? This is building operating speaking. We're going to do a follow-on audible test on T-ground and the T-first floor. You may hear the evac tones from the overhead speakers. Please ignore that. It's just a test. May I have your attention please? May I have your attention please? This is building operating speaking. We're going to do a follow-up audible test on T-ground and the T-first floor. You may hear the evac tones from the overhead speakers. Please ignore that. It's just a test. Thank you.
The literature also supports this project by agreeing that information provided along the patient's treatment trajectory is crucial, since it is known that patients have a hard time recalling information that's distressing to them. You can also find research to support the nurse navigator role and how it could help provide continuity of care and alleviate anxiety. This project also aligns with UHN, Princess Margaret strategic plans and Accreditation Canada by prioritizing timely access to information for patients, as well as improving communication to patients and providing more information at care transitions. And of course, UHN's primary value to, above all else, put the needs of the patient first. So bearing all that in mind, we had a number of change ideas that we thought up, but the three that we thought might be most realistic to complete by in our 6-month allotted time frame were to provide chemotherapy materials before hospital discharge, and also implementing proactive calls pre and post their first cycle of chemotherapy. So what that would look like then, if this time we look along the top of the poster board, everything stays the same until about week 5. But at week 5, we have a teal for Princess Margaret, a Princess Margaret nurse visiting the patient at Toronto General when they're still an inpatient and providing some of the chemo class material that's offered in the chemo class. So just to give you a quick idea here, they get a whole folder of educational materials, pamphlets and everything at the chemo class. But what I would be looking at implementing while they're still in hospital is one key booklet that patients find most useful, because this lays out logistics and side effects, a lot of commonly asked questions. So it would mean that week 5, they get the booklet, they go home with it, they can review it over the next 3 weeks at home, and then they can choose whichever chemo class they'd like to attend. So they go home with the material. They could attend chemo class the very next Friday if they so wish, or maybe they need more time to recuperate from surgery. They could then attend the following week's chemo class, or if they really don't want to investigate chemotherapy until they have that firm diagnosis, there'd still be the opportunity to attend the very last Friday's chemo class. Again, bearing in mind that from my survey that 30% of patients that couldn't attend chemo class, perhaps if they could self-schedule into one of 3 chemo classes, we'd have more attendance as well. And then looking at the phone calls pre and post the first cycle of chemotherapy, so that first call would be sometime between them attending the chemo class and actually starting chemo. So if they have any last minute questions or concerns, we make sure they have all their prescriptions and that they're ready. And then a call post chemotherapy. Right now we're looking at perhaps 24 to 48 hours post the first cycle. So again, it could be other questions or concerns, but it could also help address any side effects they're experiencing and how to manage them. And what was interesting as well from my surveys was that 64% of patients I surveyed said that a call pre-chemotherapy would have been helpful, but 91% of patients I surveyed said that a call post-chemotherapy would have been helpful. So what does this mean for sustainability? Well, ultimately, it will be informed by the data I collect throughout this project. There's a lot of things we have to consider, including balancing the patient benefit or added patient value, as well as the staff workload and the time involved. So we'll be looking at, how long is the interaction with the patient in the hospital, how long are the proactive calls, and what does this mean for sustainability. But we'll also be looking at the Princess Margaret Gynae nursing triage line, as it might increase or decrease the amount of calls coming through. Might decrease if the patients already have the material at home. Perhaps the answers to their questions are already with them at home, but perhaps it will increase. Maybe it will trigger more questions, and we'll be monitoring that as well. Lessons learned through this process is that it is just that, a process. I feel like it's December and we're just really getting to the fun part now, but I can appreciate that you need solid groundwork before you go out and try to enact change. So I have a new appreciation for the change process. I've also had to learn how to engage other staff to help, and my strategy was incentive. So when I wasn't getting as many surveys back as I would have thought, I had to think about other ways that I can engage staff to be a little more dare I say, enthusiastic, but it also helped to show face to remind them to be flagging these patients and to be administering the surveys. But overall, I've learned there's been a lot of interest in future development. When I've met with professional practice leads across both sites, everyone seems to be very excited to see where this is going to go and how this may pertain to other departments. So in conclusion, the current state offers opportunities to better meet the information needs of our patients, but where can we improve, and more importantly, what do patients find most useful? So stay tuned to hear the results of our change ideas that were patient informed and tested through PDSA cycles. Thank you. Questions? Well, I know in other departments, they already have coordinator roles or navigator roles to kind of follow patients. There is some, in the standard of practice, there is some navigation guidelines. For the gynae clinic, we don't really have much of that developed as yet, so that's my hope for the project. Thank you.
Yes. Laura, I just wanted to say how wonderful to have something very different for you for the very last intern. You know, like this is really different and really engaging, and for all those that aren't here, it's fabulous. I wanted to mention there was a stat there about 40 wanting to have the information about chemotherapy somewhere around the initial time point. However, at the same time, we're trying to balance health professionals around information. So the right timing, the right quantity of and the right information. Right. So do you want to comment a little bit about that? Like, patients requesting it earlier on. Would it make sense, and would we overload it?
Sure, thank you. So the question was, one of the stats showed that about 43% of patients said that they wanted chemo education earlier at some point between the initial consult and being discharged from hospital. And how do we decide what the best timing is for that? And I'm glad you brought that up, because I feel like though patients say now that they want the information around initial consult, I actually brought things with me today to demonstrate how much they're already getting on day one, plus they're signing surgery consent. So they're already getting 2 binders, one's for surgery and one's their cancer journey. Plus they're getting information on the type of disease they have, the type of surgery they'll be having, and then signing the consent. So I think though some patients say they want that information earlier, I think at that point, the chemo education materials would fall to the wayside. Thank you. Oh, sorry. Hi.
In terms of gynecological cancers, there's a lot of patients who have very chemo. I was just curious about collaboration therapists that sometimes have both.
Yeah, so the question was, a lot of the gynecologic oncology patients need primary chemo radiation, and so has there been any thought into collaborating with the radiation teams about similar interventions? For the sake of this project, we're really looking at the surgical patients needing adjuvant chemotherapy. Most of the cervical patients don't have surgery. Most of the cervical patients don't have surgery, but rather just chemoradiation treatments. But it is something that we'd be looking at in the future, because again, it's still that same theme of information overload requiring more than one treatment. Absolutely. Thank you. Yes, Angela. Right, that's a good point. So the comment was, regardless of when we give it, it's still a lot of information to go over, and might it be best to have it available online? That way the patient can access it whenever they'd like. Absolutely, that's a great idea, and I hope it does go that way. Because you're right, it's still a lot of information. What I thought about doing when I visit the patients in hospital is showing them all the material and asking them to pick which might be interesting or relevant to them at that time. But then I also felt like presenting so much material while the patient's still in hospital might be overwhelming in and of itself. So it's definitely something we're going to look at, and it would be fantastic if we could get it all online. Absolutely. Thank you. Thank you.
Thank you so much, Laura. Now we have Nicole Cooper, professional practice leader at Sunnybrook, to give closing remarks.
Thank you. So as mentioned, I'm Nicole Cooper. I'm one of the faculty members with this year's fellowship program, and this is my first year in a formal role with the fellowship. It's been extremely rewarding and educational for me to be able to participate. Today was the fourth and final day of our midterm presentations. It's been amazing to hear the patient stories that started you on your journey to quality improvement. We've seen a diversity of projects that span the entire life cycle and across the entire continuum of care, from inpatient to outpatient and back and forth between. Equally impressive has been the progress that you've all made in such a short period of time. Whether you followed the path that you outlined when you applied for your fellowship, or as many of you told us, if you've taken a left turn and modified based on what you've learned and demonstrated in all your lessons learned that you spoke of. You now all speak a new language with respect to quality improvement, which you've demonstrated today. I was looking for an inspirational quote to try and share, and one that stood out to me was by C.S. Lewis, the author that wrote the Narnia series. You can't go back and change the beginning, but you can start where you are and change the ending. So I think as I reflect, this really embodies where all of you are right now. You realize that there may not be a formal ending to many of your projects. We've talked a lot about sustainability and how these are going to move on. But you are changing the course of patient care, and you are changing the ending potentially for our patients. So I wanted to thank you all for attending and those joining via webcast. Thanks so much to all the faculty that's here today, as well as to Sarah for moderating the session. And most of all, thank you, as well as congratulations to all the fellows for your work this far and for inspiring us with your passion, your creativity, and your innovation in transforming care. We really look forward to seeing how much further you will travel and how much more you can accomplish in your final presentation. Have a good day.